So, hello friends. I welcome you all on my YouTube channel, Bright Academy, the home of success. Yes, I'm making this video after a very long time. So today we are going to talk about the very important topic, just known as a gastrinoma. Yes, as you all know, it is a neuroendocrine tumor. Yes, we talk about the gastrinoma. It is a neuroendocrine tumor of the pancreas, right? It is neuroendocrine tumor of the pancreas. So which are the other neuroendocrine tumor of the pancreas which you know? One is insulinoma, which is the most common neuroendocrine tumor, and other is gastrinoma. It is a second most common neuroendocrine tumor of the pancreas, right? It is second most common neuroendocrine tumor of the pancreas. Yes, as you all know, neuroendocrine tumor have a propensity towards the female preponderance, right? But here is a difference. It is more common in male. It's common in male than female. And what is the incidence of the neuroendocrine, this gastrinoma? Yes, what is the incidence? Its incidence is 0.5 patient per million population per year, right? This is the incidence, very low incidence, right? So what is the cell of origin? From where does they arises? So cell of origin are likely, understand my word, likely from G cells of pancreas. As you know, there are many cells in the pancreas, G cells, S cells. Yes, so this arises from the G cell of the pancreas. It's proposed, not said surely, right? So it arises from the G cells of the pancreas. What else? As you know, it's a neuroendocrine tumor, and neuroendocrine tumor have a propensity towards the familial origin. Yes, so this can also be a familial in nature. So how much percentage of the patient are familial? How much percent of the patient with this gastrinoma are familial, and how much are sporadic in nature? So you can see 75% of the patients, or I mean to say 75% of the gastrinomas are sporadic in nature, and 25% are familial in nature. What do you mean by familial in nature? Yes, as you know, one common familial neuroendocrine syndrome, which is known as the MEN1, right, is associated with the pheochromocytoma, gastrinoma, pancreatic neuroendocrine, parathyroid adenoma, right? So it is associated with MEN1. Yes, MEN1. We'll talk about this. So 20% of the 25% of the patients of gastrinoma are familial in nature. Yes, and it is also a most common functional neuroendocrine tumor in MEN1, right? Most common functional neuroendocrine tumor. Listen carefully, right? A 20% of the gastrinoma patient, 20% of gastrinoma patients are positive for MEN1, right? 20% of the gastrinoma patients are positive for the MEN1. So what is the median age of origin of these tumors, right? What is the median age? In which age group this is common, right? So age, its age of origin or median age is around 50 to 55 years, right? 50 to 55 years. In this age group, it is a very common. If we compare this with insulinoma, so insulinoma, which is a most common neuroendocrine tumor of the pancreas. It is common in females, to male ratio is 2:1, right? It's common in female. Yes, and its age of presentation, median age of presentation is 60 to 70 years, right? It's 60 to 70 year of median age of presentation. So we talk about the cell of origin, its epidemiology, and its functional and familial aspect, right? So what are the cell of origin, or what is the location, most common location of the gastrinoma, right? So this is this. 90% of gastrinoma are located in, yes, you are thinking it right, it's gastrinoma triangle, or which is also known as Passaro's triangle. Passaro's triangle, right? It is also known as Passaro's triangle. So, which makes its boundaries, right? Passaro's triangle boundaries are made by, as you know, no, it's a little different. It's not here, it's here. So, its boundaries are formed by the junction of cystic duct and CBD, junction of second and third part of duodenum, and head and, sorry, it's not head, right? It's neck and body of pancreas. Yes. So as you know, it's junction of cystic duct and CBD, junction of second and third part of duodenum, and junction of the neck and body of the pancreas. This triangle is the most common location of the gastrinoma. Yes, 90% of the gastrinoma is found in this triangle. Yes. So this is about this location. As we are talk about the familial gastrinoma also. So what are the difference in case of the sporadic and the familial gastrinoma? Right? What are the difference? Yes. Gastrinoma. Yes, sporadic and familial. It's sporadic gastrinoma and familial gastrinoma. What are the difference? So as we previously read, like its incidence are 75%. 75% are common. It's 25%, right? As we previously talked about this, it's more common in men. But this is, yes, this is more common in females. Yes. As we talk, it is common in older patient. It is common in younger patient, right? It is common in the younger patients. Its are sporadic are single in number. Usually multiple in number. Yes, familial are multiple in number. Yes, sporadic have less malignant potential, as we call this as a gastrinoma. Oma means benign. Yes, so it's a benign tumor having propensity towards the malignancy. So it has very less propensity towards the malignancy in case of sporadic gastrinoma. It has less malignant potential. It has more malignant potential. As you know, familial syndromes are usually associated with the malignant diseases. Yes, so it is also have a more malignant potential in case of familial gastrinoma, right? What else sporadic tumor differs from the familial tumor? Yes, about metastasis. You are thinking right. It's about the metastasis. The sporadic tumor metastasize to liver, right? Hepatic metastasis, and these are metastasized to lymph node, right? It's are metastasized to lymph node, metastasized to liver in case of sporadic tumor, and familial tumor are metastasizing to the lymph node. It's a very important point to differentiate in case of follow-up, right? This help you in a follow-up of this patient. So this is the difference about the sporadic and the familial type of gastrinoma. What else? So we can say like it's a 50% of the gastrinoma overall have malignant potential, right? Of the gastrinoma have malignant potential, but 60 to 70%, yes, 60 to 70% of the gastrinoma presents with metastasis only. Yes, presentation is only metastasis. Yes, 60 to 70%. But what is good about this? Yes, it's very good. If you talk about the other tumors, if metastasis is present, then it is inoperable and a very low survival rates. But here it is different. Even with metastasis, the 10-year survival, 10-year survival is 90%. even with R0 resection, and even with R1 resection, survival is 80 to 85%. So what does it suggest? It suggests these tumors are indolent in nature, right? Yes, these tumors are indolent in nature. Very important topic, very important point, right? 10-year survival is 90%. So these are the potential important points about the gastrinoma. So now we talk about the clinical features. What are the clinical features? How this patient presents, or what are the common findings, clinical findings in these patients? Yes, clinical features, right? So abdominal pain is the most common symptom seen in 90% of the patient. Why abdominal pain? Abdominal pain, it is due to the hyperacidemia. Yes, gastrinoma, it's stimulate the acid secreting cells. So there is a high acid production which lead to the gastritis and pain, right? And gastric ulcer also present there. So due to high acid load, there can be a gastritis, ulcer, right? What other symptoms are present in this patient? Yes, diarrhea. Yes. So what is so special about this diarrhea? It's simple, right? It's diarrhea. Yeah? So what is the so special about this diarrhea? So if it tell, it's similar to the diarrhea seen in malabsorption. So what is so special? In case of gastrinoma, if you insert RT, yes, Riles tube, and do gastric decompression, yes, then diarrhea resolves. Yes, this is so special. When you insert RT and do gastric decompression after the insertion of RT, the diarrhea resolves automatically. This is a ominous sign, right? It is very special about this gastrinoma. What other features present in these gastrinoma patient, right? What other features? Yes. So if we can talk about the non-specific symptoms. Before non-specific symptom, we can talk about the reflux symptom. Reflux due to acid, increased acid secretion, right? So which can lead to the esophagitis. And signs and symptoms like GERD, right? What are the other known specific symptoms present? Like nausea, yes, weight loss, yes, these are other non-specific symptoms present in these patients, right? So when you suspect in this patient is having a gastrinoma or not, when will you suspect? What are the criteria, or what are the features, or what are the features in imaging or endoscopic finding? Then you suspect this patient will have a gastrinoma. What are the features? What are so special about this feature? Yes. So now we'll talk about these features. Special features or features predict gastrinoma, right? As you know, it is about associated with the hyperacidemia or increased gastric acid secretions. Yes. So what are associated? When will you suspect? In case of recurrent peptic ulcer disease, recurrent, even if you treat those patients, they recur automatically in few times, right? Other is refractory peptic ulcer disease. Yes. What else? Peptic ulcer disease with diarrhea. Yes. Yes. Peptic ulcer disease in young patient. Yes. Peptic ulcer disease at unusual location. Like unusual location means, what do I mean with this unusual location? Like normally peptic ulcer are present in the first part of duodenum or in distal part of the stomach. Yes, but here peptic ulcer can be seen at D2, second part of duodenum, third part of duodenum, fourth part of duodenum, or even in case of jejunum also. Jejunum, yes, in jejunum also peptic ulcers can be seen. What else? What else? In which case you will suspect? What else? Peptic ulcer disease in a patient with known family history of endocrine tumor, right? In known family history of the endocrine tumor. What else? Yes, peptic ulcer disease associated with nephrolithiasis. Why nephrolithiasis? As you know, I have told you gastrinoma are associated with the Man-1 syndrome, right? In Man-1 syndrome, there is a parathyroid adenoma, high propensity towards the parathyroid adenoma, right? So parathyroid will lead to the kidney stone formation. As you know, in secondary hyperparathyroidism, right? It's associated with the kidney stone also, right? So in these patients, you will suspect that there are high chances of the gastrinoma, right? So these are the suspicious finding which you can, in which patients you can do a workup for the gastrinoma patient, right? So how will you diagnose? How will you diagnose these patients? What is so special about this diagnosis? First will you do a biochemical diagnosis, right? First will you do biochemical diagnosis. For this, what will you do? You will do fasting serum gastrin level assessment. Yes, what is so special about this fasting serum? If this value is greater than 1000 picogram per ml, this is suggestive of gastrinoma. If it is less than 500, then it is, repeat the test. Yes, repeat the test. But what if value comes between 500 to 1000? What will you do in this case? High propensity, high chances that this patient will have a gastrinoma, right? So here you check pH of the gastric fluid, right? pH, you will check the pH. So what you'll get to know about with this pH? Acid output, acid secretion, acid content of the stomach, right? If this is pH is less than 2.1, means there is a very much of acid, high acid content, means basal acid output greater than 15 milli equivalent per liter, right? Gastrinoma confirmed. If pH is greater than 2, sorry, it's not 2, it's 3, greater than 3, it's gastrinoma ruled out. But if this is between 2 to 3, what will you do? Again, there are high chances of the gastrinoma, so you will do a provocation test. You do provocation test. So this is algorithm. We'll continue this. Yes, which provocation test you will do? So the provocation tests are you will do secretin stimulation test, right? Yes, you will give 0.25 microgram per kilogram dose of secretin bolus, right? And you will check the serum gastrin level after 5 minutes, and if values are greater than 110 picogram ml from the baseline, then it is confirmed. What is sensitivity? Highly sensitive provocation test. Yes, sensitivity is 92%. First line provocation test is secretin stimulation test. But there are high chances some gastrinomas are not stimulated by this secretin stimulation. So what else? What else you can do? Yes, which is other stimulation test or other provocation test? Yes, this is calcium stimulation test. What is so special about this calcium stimulation test? Yes, 50% of the patient, 50% secretin negative gastrinomas are positive with calcium stimulation test. Yes, this is second line provocation test. You will not do this first. First, you will go with secretin stimulation test. If it comes negative and still you are highly suspecting that there is a high chance of the gastrinoma, then you will do a calcium stimulation test. Yes, it's a second line provocation test. So this is all about the provocation test. So by this, you confirm that this patient is suffering from the gastrinoma. So where is it? Is it in pancreas? Is it in duodenum? Where is it? So for localization, we have to do radiological investigation. Yes, this is, we confirm biochemically that there is a gastrinoma, right? So we have to localize it. So for localization, we can do two type of investigations. Yes, one is invasive investigation, one is non-invasive investigation. Yes, first we'll talk about the non-invasive investigation, right? And after that we'll talk about invasive. Non-invasive investigation, what will come under the non-invasive investigations? Yes, so which, if you're suspecting a malignancy, which investigation you will do first? Yes, you are absolutely right, it's CCT. Yes, what is the sensitivity? It's 55% sensitive. Yes, it's 55% sensitive. Which other investigation you can do? Yes, you are right, it's MRI. It's very less sensitive, 30%, only 30% sensitive. Yes. So as we know, neuroendocrine tumor, gastrinoma is having a large amount of the somatostatin receptors. Yes. So what else can you do? Very highly suggestive or highly specific investigation, somatostatin receptor scintigraphy, right? SRS. So it's, what is the sensitivity? It's 80% sensitive. You see, it's 80% sensitive. 80% sensitive. It's, what is this? SRS, somatostatin receptor scintigraphy. What else? Which else investigation, non-invasive investigation you can do in this patient, right? What else? Yes, gallium scan. Yes, you can do gallium scan. Gallium 68 DOTA-TEC scintigraphy. Its sensitivity is higher than the somatostatin receptor scintigraphy. Very sensitive. You can locate this 100% sure with this gallium 68 DOTA-TEC scintigraphy. But what is the drawback? Poor availability. It's not available everywhere, na? Even our center, we don't have this gallium 68 scan. It's available in the cancer centers. Yes. Poor availability. So this is all about the non-invasive investigation. What are the non-invasive investigation we can perform? Invasive investigation we can perform. Yes, invasive investigation, we have two investigation. First is endoscopic ultrasound. Yes, endoscopic ultrasound. Yes, it's very high sensitive, 75 to 100% sensitive for pancreatic gastrinoma. Yes, 75 to 100% sensitive for the pancreatic gastrinoma. And for duodenal gastrinoma, as we see in a Passaro triangle, second and third part of duodenum junction also comes in this Passaro triangle. So what is the sensitivity for the duodenal? Yes, it's 50%. 50% sensitivity for duodenal lesion. 50% sensitive. Yes. Which other invasive investigation you can perform? Yes. Selective angiography. Yes, you can do selective angiography. Yes, you can do selective angiography. But now in days of this gallium 68 DOTA-TEC scan, it is very less likely chances, or very less likely that you will perform this selective angiography. It's not required in days of the gallium 68 DOTA-TEC scan, right? Not required routinely. So this is all about the localization sensitivity. By this, you must, or you in 100% of cases you will localize the gastrinoma, right? So this is about localization. So after localization, you confirm this patient is suffering from gastrinoma, right? So what will you do next? Gastrinoma confirmed means there are high chances of MEN1 positivity. So you will check other component of MEN1. What are the other components of the MEN1? Yes. What are the other components of the MEN1? Yes. So we'll talk about this. This is parathyroid adenoma, pancreatic neuroendocrine tumor, other is pituitary adenoma, right? 3P, yes, 3P, it's characteristic. Yes. So what are the percentages? Percentage 98 to 100% of patient with MEN1 have this gastrinoma. What are this? Pancreatic neuroendocrine tumor, 30 to 50%, and it's around 20% of patient having pituitary adenoma. Yes. So what is so special about this pancreatic neuroendocrine tumor in patients with MEN1? Yes, majority or always non-functional, right? Non-functional, not secrete any hormones or enzyme, but if functional, then most common is gastrinoma, right? 51% of patient. If functional, then majority 51% of the patient will having a gastrinoma. Second most common functional is insulinoma. Yes. So this is about the MEN1. Which protein is abnormal? Which protein is abnormal here? Yes. So which protein is abnormal? Menin protein. Yes. Menin. What is abnormal with this menin? Premature termination of translation, which lead to the truncated menin protein. So what is so special about this menin protein? What it works, where it works? It works in the normal cell cycle regulation of the endocrine cells. Yes. So if it is normal, it can lead to the neuroendocrine tumor. As you see, this all are associated with the endocrine system, right? Yes. As you see, it's a parathyroid adenoma. Yes, it's pancreatic neuroendocrine tumor. Yes, it's also pituitary, it's also endocrine organ. So menin is associated with the endocrine tumor, right? So this is all about the diagnosis. Yes. So now we'll talk about the management. As we talk, it is a two patients are like, it's a sporadic and familial. Yes. So in sporadic cases, biochemical cure seen in 50% of patient, but here It is rare. Rarely patient is cured biochemically. Yes. Other, high chance of recurrence. Yes, high chance of recurrence at 10-year follow. It is 30% chance of recurrence. Yes. But so what is good about this? A 10-year survival with R0 R1 resection is 80 to 90%. This is what is good about this sporadic tumors, right? And what is about this familial? Yes, what is so special about this familial? They are 50% of this tumor are metastatic at presentation. Yes, and biochemical cure is rare, so the role of surgery is controversial. Yes, so this is about the basic management of the gastrinoma. As we know, there are high chances, okay, we are not able to localize gastrinoma preoperatively. So what will you do in that cases? So in 15 to 30% of the patients, there are high chance you will not localize it preoperatively. So what you will do in this case is you will go for exploration. Yes, you will do white coccolization. Yes, white coccolization up to the body and tail of pancreas. Yes, then you will do intraoperative ultrasound. Yes, still you not found, and what can you do? You can do a lateral duodenotomy. If still, what other can you do? Endoscopic transillumination. If still you not found any gastrinoma there, what you can do? You can take a sampling of the lymph node. You can take a fatty tissue. Fatty tissue means you take a lymph node. Sampling of lymph node from gastrinoma triangle, right? So by this, there are high chance you will localize with this maneuvers, right? So now what is the treatment plan? What is the algorithm? Yes, what is the treatment algorithm for this gastrinoma? Yes, first, as we are talking, gastrinoma is sporadic or familial. First we'll talk about the sporadic tumor. Yes, so whether it is a duodenal tumor or pancreatic tumor. Yes, duodenal tumor or pancreatic tumor. If it is duodenal tumor, what is the size? Yes, if it is less than 5 millimeter or greater than 5 millimeter, right? So what will you do in less than 5 millimeter? You will do enucleation. What will do here? Full thickness excision. Yes, what is about the pancreatic tumor? Whether it is situated in the body or head or body and tail. Head, body and tail. You will do distal pancreatic splenectomy. In case of head, what will you do? You will check the size. If it is less than 2 centimeter or it is away from the duct, away from the pancreatic duct, what you will do? You will do enucleation. If it is greater than 2 centimeter or it is nearer to the duct of the pancreas, you will do pancreatic duodenectomy or Whipple's. So this is all about the sporadic gastrinoma management. Yes, what is about familial tumors? Yes, a tumor associated with the MEN1. MEN1. So here you will talk about it's preoperatively localized or not. Localized? No. Then what you will do? You will do observation. If it is localized, then you will ask, what is the size? it is less than 2 centimeter, you will do observation again. But if it is greater than 2 centimeter, then you will talk about where it is. Body or tail, you will do distal pancreatic splenectomy, and head, you will do pancreatic or duodenectomy. Yes, so this is about the familial gastrinoma management. Hope you enjoy. So that's all about gastrinoma, right?